Intraosseous placement can be a life-saving means of vascular access. It can be used in any age group, although it is most commonly used in children less than 3, due to difficulty in obtaining access in this age group. Intraosseous placement is indicated in emergent situations when vascular access is required. It should never be considered definitive access, and peripheral central line access should be attempted for more permanent access. All resuscitation medications and continuous infusions can be run through an intraosseous needle, although the rate achieved will often be lower than that achieved by central venous access. Before beginning any procedure, make sure to have all necessary supplies available. For intraosseous catheter placement, you will need a prepackaged intraosseous needle, antiseptic solution, drapes if desired, saline flush, syringe to aspirate, hemostat for stabilization after placement, tape, and resuscitation fluid. The tibia and the femur are the most commonly used sites, with the proximal tibia being the preferred site in children less than 4 years old due to prominent landmarks and decreased overlying subcutaneous fat and muscle. Landmarks for the proximal tibia are 1 to 2 finger breadths below the tibial tuberosity on the medial portion of the bone. The medial portion of the bone will provide a flat, stable surface for insertion. Begin by placing a towel or drape underneath the patient. Then clean the site with betadine or other antiseptic solution. You should hold an intraosseous needle with the ball of the device in the palm of your dominant hand. Hold the distal portion of the device like a pencil with your thumb and fingers placed at the designated line marking on the device. Before inserting the needle, note the stylet tip protruding from the end of the needle. Apply a rotational back and forth screwing type motion until you feel an abrupt, sudden decrease in resistance or give. Avoid rocking the needle back and forth as much as possible to avoid creating an excessively large entrance hole, which cannot stabilize the device. Once the needle is inserted, the trocar or stylet can be removed. If inserted properly, the needle should be secure in the tibia and often can stand up on its own. Once the needle is inserted, you can attempt to aspirate marrow, although this is often unsuccessful even when the needle is inserted correctly. If saline flushes easily without causing calf or subcutaneous swelling, you can be confident of successful placement. Once you are assured of proper placement, you can connect resuscitation fluids. The line should then be secured in a manner that does not block visualization of the site. This can be done with a hemostat and tape.